one or correct? There we
Okay.
go. So the answers we're getting with regards to the question is 1, 7.
Fantastic, Bob. Yeah, within oroantral communication. So this happened with one of the dentists in our practice. You can see there's a root that's there in the maxillary sinus. And the next pictures we're going to look at, the first picture you'll see is a zoomed in that area there, which is now this here. And you can see the oroantral communication here. There's the root sitting there. The following pictures have been taken by an oral surgeon. I don't know how he will have got that root to upright and flip over. Perhaps he will have slapped the patient to see if he could get this thing flipping around inside the sinus. But then, yes, it's on its way down. And he managed to tease that through without too much fuss. And then closed up that oroantral communication. So nice example there for you. Something like this, I have seen this only once in 40 years now, close on 40 years. What do you see?
So a lot of the answers we're getting are fusion of 4, 7, 4, 8.
Fantastic, fantastic. Yeah. So you know, I've only seen that once in my career, so it's that rare. And imagine if you had to root treat that. That would look really sexy by the time you finished root treating that. So here we are. There's the tooth clinical view. And you can see if you're comparing the fused 7 and 8 compared to the 4, 6. So that 7 was probably heading to about there, perhaps. And then you've got this 8 fused to it. Interesting. And something interesting here now on the 3, 7 and the 4, 7. Can anyone tell me what they're seeing here?
So the answers we're getting are enamel pearl and paramolaris.
Okay. What I've seen here is these are 3 rooted lower 7s. You've got your mesial root, you've got your distal root there. And then there's a 3rd root. You're following the periodontal ligament space to the mesial of the additional root and to the distal of that additional root. And we've got exactly the same happening there. You can see your mesial root and you can see your additional root there and a little bit from there. I'm sorry, I don't have periapicals of this. It wasn't regarded as going to be an issue, so I hadn't taken that any further. I'm seeing this patient for the first time, elderly patient. They've had some endodontic work done, a broken down 26. I've taken a couple of bite rings. What further radiographic investigation would I want? To do for this patient?
We're getting a lot of PA and OPG.
Right. Okay, yeah, so that's good. That's good. Yeah, you want to make sure that periapically everything is healthy. So the first step in my case would be to do an OPG. And there we go. So we're seeing this OPG. And you can see there's a very, very large periapical lesion on that tooth. And of course, we would not have seen that otherwise, unless you did this further investigation. That's good. Moving on here. Something very, very unusual on the in the upper arch. Which would be a dentist or an oral surgeon's nightmare. Okay, is that?
Divergent roots of the 1-7
Yeah.
and ankylosis, possibly.
Very good. So, yeah, you can see this is a massive tooth. If you were hoping to do a straightforward forceps extraction of that tooth, it's just not going to happen without you breaking something, because the maximum width is from there through to there. How are you going to make something that wide come out through something that narrow? It's just not going to happen without something giving. You don't want to be bringing out a whole lot of bone with that. So let's go to the next picture, and you can see 4 roots. So there's one root there, there's another root there, another root there, another big root there. The same here, you're looking at 1, 2, 3, 4 roots. But what struck me was how massive, how divergent everything was there. The tooth looks tiny in the mouth. It's a monster up in the bone. Okay, so an impacted 2-3, the 63 is still present, 23 is impacted. How would you tell from these x-rays whether it's palatal or buccal? Very good, very good. So we've gone on a tube shift. We've gone from this picture where the canine is sitting over the mesial of the tube. I've moved my tube across to the left, and we are now sitting, you can just barely see the tube. We can't see the central incisor. So we've done our tube shift. And is this tooth placed palatally or buccally? Okay, that's good. That's good. Yeah, excellent. So the next OPG is going to be the same patient. By the time we get the patient over to the orthodontist, you'll notice that 63 has fallen out. You can see where the impacted canine is sitting. And going on to the next picture is he's now in fixed appliances. Space has been made. There isn't enough space there for the canine to fit into the arch. Space has now been created with the power chain across there. And you can see the canine starting to fall through quite nicely. And looking at him today, everything is off. And the orthodontist has achieved a beautiful result. He's in class 1 molar occlusion, class 1 anteriorly, that canine's nicely done. This lad's younger sister presents with the same thing on the other side. I think she's maybe a little bit more crowded. If you look at that canine, for the young lad we are talking about, it's gone across as far as sitting over the distal of the 2-1. His sister, it's much further, much further across. It's I don't know. She's just gone in. She's gone into braces. This was a picture taken earlier this year. She's got the braces on. A massive amount of space has been created there. There's ample room for the canine to come down. I don't know. The orthodontist will probably wait for a little while to see if it's going to come down on its own. If not, then they'll need to surgically expose it, bond a bracket onto that, hook elastics, and start to drag it down into the arch. What's this poor soul suffering from, or what do you see? Very good. congenitally absent all second premolars. The ones that are most commonly missing are the 3, 5, and 4, 5. Second most commonly missing will be the 1, 2, and the 2, 2. In this particular case, you can see all the premolars are missing, and the second premolars, the 5s, and patient's really bunched up there. I don't know overall in the grand scheme of things whether space is going to be needed and whether those E's will be sacrificed. You can see that 2, 2 coming down. It's trying to sneak into that little space. It's rotated a good 90 degrees. We're probably seeing it's of mesial to distal or distal to mesial rather than buccal to palatal like that. 1, 2 there. So this one's twisted 90 degrees. It doesn't look like it's ever going to be nicely positioned to resorb the root of that 2, 2 away to push it out as it comes down. So time will tell. This patient's got a lot of growing to do still. Okay, so you'll see something like this. The patient says, please, can you help me? I've got pain. This tooth of mine is really sore. You have a look at the tooth, you smile to yourself and you say, nurse, please can you give me some gauze? I want to take a tooth out. But be very careful, please. I've come across this situation once before. A patient had presented on a Saturday morning with a 48 across on that side, extremely mobile, looking like that. And I thought, okay, well, look, let's take the tooth out. Let's get this patient out of trouble on a Saturday morning. And next thing we had a massive bleed on our hands. I was working with 2 dental assistants, so we struggled really to control bleeding on that patient. There was full-time suction going on there. He was bleeding very heavily. We had to use Surgicel. We sutured up very tightly. There was firm compress for quite a long time. Initially, the compresses were filling up with blood within, like sort of 10 seconds of me placing that up against the whole sutured socket. I spoke to an oral surgeon. The nearest oral surgeon was 450 kilometers away. And he said to me, have you got any bone wax? And I said, I don't have any bone wax. I wouldn't even know how to place it in the area that would have needed it. We got the patient to take Quinacian, which is a vitamin K tablet, 2 vitamin K tablets. It promotes clotting. We had a vitamin K rinse as well. And kept him close on an hour in the surgery and monitored to make sure that he had finally clotted. So what I'm going on about is if you ever see something like that, just be very careful. Be warned that don't go in too lightly and think, okay, look, I'm going to take this tooth out. Rather refer the patient to an oral surgeon, particularly in this mouth where you're not seeing. There's an enormous amount of bone loss there. There's absolutely nothing, anything remotely like that elsewhere in the mouth. So the question, you've got to question, why has this happened? What's unusual about it? And please refer on to the oral surgeon for something like that.
Mohammed, we have someone asking if that was due to hemorrhage from the inferior alveolar artery.
I don't think so. With I don't know. I don't know if, if with the particular one that I took out, there was no resistance, and if you thought maybe resistance to this root maybe being hooked up against the artery and you've maybe torn it on the way out, there was absolutely no resistance. I really do not know why I encountered what I did. Okay, unusual finding here.
So we have supernumerary 3-3.
Very good. Yeah, tubercular sitting upside down, all across there.
We've got another response. Mucus retention cyst, left-hand side sinus.
Yes, there is. Yes, there is. Across there. Mm-hmm. Okay, a couple of impacted teeth. We're looking at 1, 1, 1, 1, 2. What tooth do you think that is? What number? What number? What number? So this one here, being tooth number. Very good. 1, 4. Over there, the impacted 3, and then the 5. Elderly patient, lots of wear, incidental finding. If they're not after any dentures, those will probably sit there undisturbed. Lots and lots of infection, lots and lots of infection there. You've got sort of large periapical lesion there, periapical lesion there, almost cystic in size. Large periapical lesion bordering on a granuloma. If you compare that to it appears that you're starting to get quite a deformed lining across there. And this is when you start to think, okay, maybe this is now cystic in nature. Yeah, you'll see further down a few x-rays where we've done endodontic treatment and a large lesion like this has disappeared without surgical intervention. But yeah, there's lots of issues here. This patient's in a lot of trouble and is needing a lot of extractions. We probably need a lot of curettage there in particular. Okay, two problems from two disciplines in dentistry here with this patient looking at the OPG. If somebody can come in there.
So getting endoperi lesion on the 1-6.
Fine. That's fine. Something else, one more? One more issue, sorry. Okay, 32, yeah, 32. So when you, of course, and you know, I'll see a patient as a new patient, I'll take bite wings, get an OPG done. When you're seeing something like this, because the vertebral column is superimposed over this anterior area, this bigger. This is the tongue, the line of the tongue, by the way, all across here. Yeah, that would be the hard palate. And then you've got this air space along there. And when that is superimposed over this area, plus the vertebral column, sometimes you think maybe something's going on there. Make a decision between clinical appearance, any symptoms, and whether you want to take radiographs of that area. But certainly when I'm seeing this here, we've taken a radiograph there, we've taken a radiograph there, and this is the first of them. There was absolutely nothing we felt we could do for the 6. It was so mobile. I thought possibly, I sent the patient off to a periodontist. I thought possibly because there wasn't a horizontal bone loss, there was a vertical pocket with still some bone here. I thought maybe with the raising of a flap, cleaning everything up and putting something like endogain or bone in there may have been a way of trying to save 4 and the 5. The periodontist felt otherwise, that they couldn't be saved, and those teeth were removed. So here we've taken the PA of the 4-2, showing a distinct periapical abscess. Something that I'll show you particularly for the students is you might do endodontic treatment on this patient. So here we're doing CMP on that visit. This is my try-in of my final point and the obturation a week later. And this is now a remarkable improvement in the space of about 8 months. A lot of that lesion is disappearing. And less than 2 years later, almost complete resolution of that. And I think the main reason I'm throwing all of this up is on clinic. Final year students, 4th year students might be doing this root canal treatment, but you're not there later to follow up and see how everything's worked out. There'll be one more picture because I've seen the patient recently. So we've got that original. We've got this one of 2 years ago, and then this one here taken a few weeks ago. So you can see further consolidation of this area. There was just slight thickening of that periodontal ligament space and some further improvement there. So this patient's done well, going from one to the other. Okay, interesting things here. How not to do dentistry, maybe. Okay, yeah.
So we're getting a lot of poor endo on 4-6 in our responses.
Yes, and 3-6. Well, no endo down those canals at all. Okay. Sure. What are these things? Are these things here floating around up there? What are those?
Abrasion lesions or class 5
yeah,
fillings?
Class 5 fillings is what we're looking at, yes. Okay. So, yeah, that tooth was taken out. There's an implant replacement. That was taken out, implant replacement. And the rest of the mouth is quite stable. Okay, so earlier when we had that supernumerary tooth, and then we saw a polyp in the one sinus. So we've got the same thing here, a polyp sitting in the left maxillary sinus. Infected tooth there. These teeth are not in the gray sort of shape. Caries here, but the main reason I've put this X-ray up is just to show you the polyp that's there in the sinus. Okay, let's have a look at teeth here. What's going on in this patient?
Supernumerary distomolar 1-8 and 2-8.
Okay, yeah, so we're looking at your, that's fine. So, extra tooth there, good. And the reason for this picture was to show up an additional root across there on the towards the lingual of that, or distal of the 3-6. What's that there? Okay, good. Good, James. Okay, so let's just talk about that there and that there a little bit. There's unless you're seeing discolored teeth, unless there's been a history of trauma, you wouldn't expect anything to be going on there. This is, again, that superimposition of the vertebral column. We're looking at that tongue space across there. We're looking at the hard palate sort of up across this region. And from here, you can see that extra black. And this is, we've got this little sort of droopy lip shape of black all across here superimposed. If you were worried about this, by all means take periapical radiographs, but there's something here on this picture that I want you guys to pick up, something here other than looking at that and other than looking at that. A carotid stent, well done, yeah, and there we are. Across there. Why is that tooth looking so odd? Okay, very good. Yeah, very good. Very good. And as far as the 38 is concerned, it's probably tilted maybe 45 degrees or so. But yeah, certainly with that, yes. And then, of course, we've got this impacted canine. Again, a case of a 2.6, 2.7, 2.8, and a 2.9 sitting there. So we're seeing that. We've seen that quite a lot. And an opaque maxillary sinus there compared to the other. And the same thing there, an opaque sinus compared to the other. So if, as you know, if a patient comes to you, you can't see anything wrong, and they say, I've got this dull, everything feels dull, feels a little bit tender, there's no thermal sensitivity, there's no aching. And you'll ask them, you know, do they feel a heaviness in their head? Do they feel heaviness when they tilt their head forwards? Have they got a blocked nose? Is the nostril blocked? Do they suffer from sinusitis? And as you all know, that's a massive airspace. We've got one of the largest air spaces in the skull. And when it's blocked up with fluid, that extra weight running, pressing up against the nerves that supply these teeth can make them feel different. It's not painful, it's not toothache, things just feel different. Okay, anything interesting here?
So the answers we've got so far: impacted canines, your dens, external resorption on the 3.7, and impacted 1.8.
Okay, and the main feature here on that 1.8, it's uninterrupted, is it's undergoing resorption. So we had a similar case a few X-rays ago. There's caries there, but the main feature here is that I'm not sure about the mesodens in that area. And that somebody said about a canine next to the orbit, but the canine sitting here, yeah. Okay, so again, you know, I mean, we've got an impacted tooth, but here we are. Here's a tooth completely buried, still covered by bone, and starting to undergo this internal resorption. Anything interesting on any tooth looking different to the others here? Okay, yeah. So the pinkish in the pulp is visible, excellent. So let's go on to the radiograph. There's the pink spot there. And here we are. a fairly aggressive internal resorption of this tooth, you're ending up with a very, very thin shell of tooth extending to what, a good 3-4 millimeters below the alveolar crestal level, and this tooth was extracted. Okay, so this tooth here, we took a PA because this tooth here appeared discolored when I looked at it. The picture doesn't show it up too well, but here we are. And you can see between the coronal third of the root and involving the entire middle third of the root, there's, and this is what's happened post-trauma many years ago. There's no periapical pathology. The patient has no symptoms whatsoever. Not the greatest of teeth, lots of crowding. We need to do a good cleanup. If this is not giving the patient any problem, then we would maybe leave that completely behind. So again, we've got crowns across there, a discolored tooth across here. And again, we're seeing the same thing. There's been a fracture of this tooth, no periapical pathology, there's no symptoms whatsoever, and a clean break across there. The root canal's pretty much disappeared all the way up there. And we'd leave that completely alone. And that's the same patient with and on the OPG. Same thing here, discolored tooth, incidental finding, he's not complaining about anything, and we take this and wow, look at the, I'm surprised he hasn't complained of anything. I'm surprised it's still in his mouth looking at that. And of course the discussion here is going to be looking at a good long-term solution, whether we use any orthodontics to close some of the spaces there. We're looking at an implant or a removable denture, whatever the patient wants. He's got to decide between removable appliances or fixed appliances for that. And then we're seeing now crack lines across there. There's been trauma, particular discoloration of the 2-1, some discoloration of the 1-1. And what's happened here now? With the others, we saw there was no periapical issues. We saw the fracture lines. What's happened here? Pulp canal obliteration. Yes, very good. Okay. And fortunately, you know, everything's all fine. We would maybe want to, if he wanted, perhaps whiten those teeth for him if he's not concerned, leave those completely alone. If he's got aesthetic concerns, of course, there's options, but if he's got no concerns, this was an incidental finding, then all fine. Little gum boil there, lingual to the 32. And that's what's happened. We saw one where there was this massive internal resorption happening on that 3-3, and it was happening quite aggressively, quite high up. This is happening down in the sort of the lower 2/3 of the root with a massive lesion. Wasn't easy to get this tooth out because, as you can imagine, that was very, very friable, the tooth at that stage, eggshell thin. This patient presented with soreness up quadrant 1 towards the back. We had a look, the bite ring showed nothing. We took another radiograph going a little bit further back because a lot of the tenderness was sort of distal to the 7 area. And what we saw there now was an 8, and this was now starting to dissolve away on this patient. So you can see we've seen many examples of this, and there he is on the OPG. The 280 is fine. This one here is just starting to resolve away. It had become infected. I think there may have been an opening there, and this tooth needed to be removed on that patient. Okay, prognosis for this tooth there, anyone?
I think everyone's agreeing with not great or hopeless at the moment.
Okay, fine. You will see, oh wait, there we are, okay. You'll see in a later slide where I had come across a patient many years ago where somebody had done root canal treatment on that hemisection, taken this out, and tried to get the patient to hang on to the 6 sitting on the one root. Yes, in this patient's case, we did extract that tooth. Prognosis really poor. Okay, let's count teeth across here. You're looking at 1, 5, 1, 4, 1, 3, 1, 2, 1, 1, 2, 1, 2, 2, 2, 3, 2, 4, 2, 5. And that is a supernumerary, a mesiodense sitting there. Commonly sitting in that position is going to be the cause of a diastema, a large diastema there. Just keep a watch on the 31 as we go on to the next couple of pictures. It's labially placed. And if you're looking carefully, it's quite yellow compared to the other incisors. So this is what raised concern because of the discoloration of the tooth. And we've taken this PA. Again, trauma, the canals become very, very fine, but there's a large periapical lesion. So when you're seeing discolored teeth, you know, palpate the sulcus, push against the tooth, question about any symptoms. May be wise to take a radiograph to make sure that there isn't anything like this going on. You can get chronic pathology and the patients don't know about it. So seeing a patient for the first time taking bite-wing radiographs, there's an Emax crown there. Somebody hasn't cleaned up the cement after that was cemented on. Take an OPG because there's a lot of endodontic treatment being done, lots of crowns, a lot of bigger work, and we want to see what's going on. So what do you see apart from that we talked about? Two things mainly in the upper arch. Okay, 2.5 PA pathology. Okay, fine. Okay, so that amalgam to 2 dislodged into the canal for 2-2 is no. This is a classical sign of an apicectomy. Looking at this, we don't have a PA. It looks like there may not even have been endo done. You've got a post in there, you've got a crown. There will have been pathology. A flap will have been raised and apicectomy done, and then a retrograde amalgam placed in the tip of the root there. And there's the periapical pathology on the 2.5. Those are okay. We'll go on to the next picture showing the 2.5 periapical pathology. And again, more for the students here, just to be able to see that after you've endoed that, when you follow up 2 years later, almost complete healing in that area. Note also when the sixes go, when other teeth go, how low down the sinus floor comes together, virtually in contact with the ridge. So we had that case going back there where we talked about the apicectomy. So this is an English dental assistant who worked for me maybe 2005 or so. So we're going back 15 years. She's got a porcelain jacket crown on there. This is pre-Emax days. There's a cast post and coin. The endo was done. She'd already had an apicectomy done. She said she'd had it done twice, but there was a large periapical lesion. And when she was working with me, there was a discharging sinus from that. Sometimes you want to, so we went back and we redid all of this for her. You might want to raise a flap across there, but you don't want recession to occur there and the margins of the crown showing. So if you're going to do a semi-lunar flap across there, just make sure that you've got to assess where after you curate the bone, that you're not going to suture over an empty space. You've got to make sure that your flap is going to be back over where there's bone. So we raised a flap. We've done an apicectomy. We've curated out that whole lesion. I've put in a retrograde amalgam in there, sutured over. You can see I've not been tidy. I've left spicules of amalgam there, and little bits all along the bottom of the lesion that we've curated out. So large. And then this is a year later. So that has worked out really well. That healed up really nicely for her. And earlier, we had that patient who had multiple large abscesses, granuloma cyst, and I said, you know, occasionally you'll come across an extremely large lesion. You'll come across an extremely large lesion. This was an incidental finding. The patient had no symptoms whatsoever. So sometimes that's how chronic things can be, and the patients aren't feeling anything. And this is around the time that we've coming to cleaning everything out. And this is a few years later where things have healed completely there. And then a similar case, just tracking there. This will have been a GP point going through the sinus, picking up exactly where everything's coming from, when we're cleaning, when we've obturated, and then things have healed very, very nicely for this patient. Okay, what's interesting about the one of these lower molars here? Very good. Okay, yeah. So we've got that extra root sitting about there. Canals, one there, another one will be coming in across there. Another one's coming down across there. Another one's coming in across there. And there we go, obturated with that extra canal. So you look in the mouth, patient comes in, you think they've got a little bit off the 1-4 that's come through, that's remaining, and you think, okay, well, I'll just grab that and take it out, and you've got a big surprise waiting in store. What's the big surprise on this tooth? Yeah, both massive hypercementosis. That's not going to come out without a fight. It's interesting how you just don't see any pulp at all there. Okay, right. So I'll just talk to you about this sort of area first up. Patient comes in, and I've seen this on clinic. I've seen this with the students. Patient comes in, look, I'm having problems chewing. You look in the mouth. Sometimes the the exam pack mirror probe packet hasn't even been opened. And the student may come up to me hypothetically and say, look, part of a filling's missing on the 7, I want to fill it. You ask the patient to close, and you can see that the reason why that's worn as it is because of the opposing 7 biting right into the so this was just hypothetical, but the big issue here, would you do any further investigation radiographically for this patient? Okay, so there we go. Prognosis, I've got tongue in cheek there when I'm asking that prognosis. Okay, yeah. And the reason why I'm asking for prognosis is because many a time I'm coming across with the students that they've seen this a few visits ago, they've referred the patient to postgrad perio. What can they do for this patient? And I'll say no more. Prognosis is poor. Okay, so here we are. Poor endo and any periapical pathology. We are here, yeah. Any periapical pathology, sorry?
We've just got one answer so far,
Yeah,
osteosclerosis and hypercementosis of the 1-4.
Okay, okay, right, fine. And what we've got is the interesting feature here. Yeah, we've got the hypercementosis of the 4, fantastic, yeah. You can just make out where the tooth may have wanted to be. And then you've got all this hypercementosis again. Looks quite different in another view, but yeah, extremely poor endo, but no periapical pathology. Why is that root filling and that root filling looking brighter, so much brighter than the other root filling?
The general consensus seems to be silver points.
Very good. Yeah. Excellent. So the same thing there. We've got silver points, and just focusing on this area here on the next picture. Again, just denser bone across there. Well deficient root filling, silver points, and no periapical pathology. When you see something like this and you're doing your endo, just try to keep in mind that there may be a delta or lateral canals on a tooth like this. And there we are. You can see the lateral canals that this patient has. When you revisit this on a radiograph a year later, you'll see that that cement will be gone. The body is able to resorb that. Interesting here, what main issue for this patient? Okay, yeah. We've got severe perio, localized perio, bruxism, certainly you can look at the wear there. It can lead to quicker bone loss than on somebody who's not a bruxist. Heavy chewing forces in the presence of inflammation does accelerate bone loss. I don't know if you guys come across the term or whether the terminology has changed nowadays, called juvenile periodontosis. Have you come across that, where traditionally it affects the first molars and the upper incisors more than other teeth? This is pretty much an across the board horizontal bone loss, but there's more vertical bone loss there, more vertical bone loss there, quite bad bone loss there. And this is almost bordering on that sort of thing, but yeah, quite a severe perio here. And this lady was close on 80 when she came to see me. And she says to me she's having problems chewing. Things are starting to become tender. Again, no excruciating toothache. Just can't chew like she used to. Things are different. And, you know, you have a look in the mouth. You can see, you know, grade 2, grade 3 mobility, severe perio, deep pocketing. When I discussed this with her, and I said to her, you know, ideally, we're not going to be able to save a number of these teeth. We need to do a thorough clean. You need to clean better. I'm telling an 80-year-old who's seeing me for the first time that she needs to clean her teeth better. That didn't go down too well. I have not seen her again. But yeah, chronic perio, no excruciating toothache. You know, I wish I'd seen this patient 60 years earlier and we could have advised them on what causes what. Okay, so is there caries anyway?
One six and secondary caries.
Okay.
And
okay, so 1-6 and 4-6. So we're talking about this area here. We're talking about that area there. When we're talking about this area there, please keep that little line in mind. Okay, when we go forward. Same patient, caries anywhere. Again, let's see which teeth. Okay, good. So 2-5, 2-6, 3-6. Again, we're looking at that area there. We're looking at this area all across there. And I'll ask you to, and the 7 across there. Okay, so I'll ask you to keep in mind that you're seeing this radio opacity there. And let's go on to the next picture. Those x-rays, when I saw this and when I saw that, and you'll see this case in my book on caries, over about 10 or 11 pages. I wasn't convinced that this was caries. I sent it on to 3 colleagues of mine. Total, I mean, each of them had over 20, 30 years experience. And back came the answers, lots of caries or no caries. So I decided to investigate that 2-6. I have made in that 2-6 a little hole. And as soon as I've got through that composite, I'm seeing something very, very opaque. And it turned out that this patient had radiolucent liners underneath all those fillings that you've seen. So I just simply closed that hole up, that investigative hole that I was doing there. And here we are. So I've left her alone. Here she is, August 2015, July 2 years later. Exactly the same. There was no caries. She had no symptoms. Clinically, everything looked absolutely fine. She was a regular attender. All that happened was that whoever's done the lovely work that they did had used radiolucent liners, GIC, radiolucent. Please, whatever you do, don't use radio opaque materials all the time so you don't get up in quandaries like this. Very interesting. So I said, keep in mind that, you know, those is what led us to suspect, look, you're not going to expect this when there's deep caries, there's no symptoms, no sensitivity to hot or cold. Okay, yeah. I've got this slide up because what I want to show you is when you've got, say you've got caries underneath the restoration and it's starting to spread inside the tooth. What do you expect the tooth to be doing? If somebody can just mention to me what they would expect the tooth's response to be in the advance of, okay, fine. Right, very good. So we're talking about sclerosis, tertiary dent information of the dentine tubules, and that's great because what happens is the body starts to form secondary dentine. It doesn't like the fact that decay is approaching the pulp, so it's starting to occlude all those dentine tubules, and it's occluding them and it's occluding them until this looks quite sclerotic. It's if nothing's happening, this is the body's own way of trying to protect itself. Just like when there may be a large periapical lesion and nothing's happening and there's all the gunk building up in the body wants to get rid of it by tracking through the bone and discharging into the mouth through a sinus. The body releases itself that way. So yeah, secondary dentine. Okay, what do you think this patient's suffering from? Okay, yeah. So we've got chronic periapical, chronic periodontitis. You can see the calculus supragingival, subgingival, alveolar crestal bone loss occurring in places. Yeah. Young patient, this might have been about 9 months ago. Regular patient of mine, regular attender. We noticed this swelling. We'd never seen this before in his mouth. He said that area is a little bit tender. And we took this PA. And this is the only time I've ever seen this. Just outlining this for you. A solitary bone cyst. Sort of teardrop shape. He suffers from multiple sclerosis. He's wheelchair bound. His mum's looking after him. He's maybe in his late 20s. And their decision with the oral surgeon is they were going to leave things alone. They weren't going to do anything more. When I read about the solitary bone cyst, apparently it has a very, very friable lining. One either enucleates that, or in his case, they decided that they were going to leave it alone. Some lovely dentistry here. What is that there? Okay. Looks like a TMS pin brand. And of course, one needs to do fix things up there. Okay, anything, so here we are, look again, there's, that would not be caries. You can see that material there is too clean cut. So the use of radiolucent liners, again, underneath there, all of that's a lining, GIC lining most likely, radiolucent, same thing across there. But what's going on here, what's going on there? Resorption again. And that's the same patient. That's the same patient with the resorption occurring. Okay, so again, everyone's picked up that these are buccal cervical abrasion lesion restorations. You can see there's been quite a lot of bone loss in this patient, almost down to the bifurcation there on the one side of the tooth. We're probably looking at lingual buccal or buccal lingual coming across there. There's been a fair amount of abrasion, restorations that have gone in, but yeah, quite a lot of bone loss. It doesn't appear that there's any active bone loss happening at the moment, because you'd expect to see some thinning out of the alveolar crestal bone. The reason for this radiograph is to show you that when you take your bite-wing radiographs, try to standardize the way you take them every time, so that when you are taking radiographs years later, you can still do comparisons 3.5 years later between the top pictures and the later ones taken 3.5 years later. And certainly if you're monitoring or tracking something, then you can do good true comparisons year after year after year. Even be able, if you're getting your angles right, then you can also look at the alveolar crestal bone, and you can see if that's being maintained or if people are losing bone anyway. That's probably improved a little compared to previously. So certainly at Griffiths on the clinic, you've got your different holders for your bite wings. Now and again, there's those form bite wing tabs. What I like to do is to use these little bite wing tabs. The whole reason why you're taking a bite wing radiograph, the whole reason why that name came about is because the patient's bit on a little wing, a little bite wing tab, and that is it. So that's stuck down onto your plate, and you look at it side on. And when the patient closes,
so reminder, can I get everyone to keep their microphones on mute, please?
Thanks. So when the patient closes, and this is the, so I'm using that for all my bite-wing radiographs, and the significance of that I'll come to in the following radiographs. And this is the RIN holder that I'll be using for my periapicals, for my posteriors, and for my anteriors. You have these, the other term I refer to is as the crocodile clip, the RIN by X-ray holders. You've got them in dispensary at Griffiths. So the significance of being able to use the bite-wing tab is that when the patient closes, the upper and lower teeth are pretty much approximating to each other. So that if this patient had a DO filling that needed to be done on 36, you look at the radiograph and you'll say, well, I've got to make absolutely sure that when I build this up, I'm not going to leave that marginal ridge there. I'm going to make sure I bring it down, because if I don't, that tooth is going to smash away my filling. Now and again, when you guys are in practice, you look at the tooth, you'll notice from a DO restoration or an MO restoration, a little bit of the filling is missing in the contact area. And it might be because serious attention was not made to occlusion at the time the restoration was done. Perhaps even more significant in a patient like this, if food could scream when we bit into it, the food in this patient's mouth would be absolutely screaming, because you can see the phenomenal wear that has taken place. Look at the amount of enamel that's being worn away in this patient's mouth, but more importantly, in the process, they are absolutely locking into each other so tightly. And this is where, if you ever needed to do restorative work for this patient, you need to know exactly where your restorations need to be, your marginal ridges. Of course, you're always guided by the adjacent tooth marginal ridge. But let's suppose a couple of teeth were broken, then I will often have the bite wing up on the screen behind the patient, and I'll look at that, and I've studied it, and I know where I want everything to be. So this patient, this was very, very recent. Patient came in and he said that this filling had fallen out. When he had just bought an air flosser, using the air flosser, the filling fell out. And of course, we know that an air flosser on its own wouldn't throw out a big filling. There was very, very deep decay. And after discussing with him that there might be pulpal involvement, we restored this tooth. But again, see how relatively high up I had to keep my marginal ridge when I built up that 7, because this tooth here was biting right into the we'll be looking at a periapical in the next radiograph of this bridge across here. So we've got an OPG taken. You can see again, here's a wisdom tooth that's rotated quite markedly, that's leaning back quite markedly. And we've got periapical pathology there, we've got periapical pathology there, and there we are. So now, you know, this is something that's impacting quite severely on this bridge. You know, do we go for re-endo because you don't want to compromise the bridge? Or do you section this there, take that out, put an implant there, put an implant there? But, you know, certainly when you're seeing the patient for the first time, and that's the reason for the following radiographs, is don't just leave things as this. This patient's had quite a lot of other work done, bigger work done. So follow up, make sure that there's nothing else that's going on. Very often in a situation, if we leave aside the bridge, I will come across, and you will come across, so many situations of a patient where you pick this up as an incidental finding, they're getting no symptoms whatsoever. It's your duty to explain to them what's going on. Maybe you don't want it to be there. What are the different options? And you'll say to them, well, you know, would you lose the tooth and have an implant there? An endodontist isn't going to revisit all of this, even though there's no pathology, appears to be no pathology there because of the post. You may not want to subject the patient to an apicectomy. So are we looking at an extraction? And the patient may well turn around, and this is going to happen to you, that, look, I'm this many years old, I'm 60 years old, I'm 70 years old, it's giving me no trouble, I will leave things completely alone. But then document your records, make sure it's documented. This was again radiographs just showing how when you're taking your bite wings, you are taking them consistently the same way every time. Okay, issues here. What are people seeing on this radiograph so far? Okay, so we've got open contact 3-5M, okay. Bone loss, okay. Overhang 2-6 mesial and distal, okay, fine. 3-6 mesial, fine. So we've got an Emax crown on here. there's a defect across there. So you need to go back, I mean, clinically examine the patient. Have you got a probe that's falling into there? If you've got a probe that's falling into there, ideally you're needing to replace that before things get worse. If the margins all appear to be intact, this is a tougher call. Do you still replace that? Do you say to the patient, look, keep this area clean, floss, floss, floss 10 times a day, and I'll see you for your regular checkups, but a year from now, we're going to take another radiograph and we're going to compare between this one and the next one. So the other thing is sometimes when the span of the arch from mesial going through to distal is large and you're not quite capturing everything. We're just seeing at the picture here, this could be decay. So let's see. So we take this X-ray, and I've gone further back. So we've seen this picture. I'm not going back far enough. I'm not seeing enough of the 7. And we take that X-ray, and this confirms to us on that heavily filled 7, where you've got something like zinc oxide eugenol underneath this massive amalgam sitting in contact with that pulp. There's more decay there. But now that we've taken that picture, what do you see down bottom? More importantly. Okay, unerupted 8, right? Very good. And what would you do? Would you do any more investigation? OPG, very good. So let's do that. So we're seeing this area here. I'm suspicious because the follicular space is enlarged all across there. We send the patient off for an OPG. What's going on? Very good. Dentigerous cyst is what it turned out to be. Yeah. So one thing led to another. Hey? Here we were at that. And if we left things be and didn't follow up further, we picking that up, we're seeing this, we're following things up further, and then you're picking this up. Again, massive relationship to the ID canal. This thing here is sitting right over the roof of the canal as well. Okay, so quite aggressive resorption periapically. Quite recently, we've root filled this to there. I don't have a follow-up radiograph as to how that's healing. Okay. So let's suppose this patient is 70 years old. There are overhangs on the 26 mesial, little bit on the 3/6 distal, massive overhang on the 3/6 mesial. Okay, so they're there. How much damage have they caused? Okay, right. So we're getting minimal perio, minimal to no damage. We said this patient's 70 years old. You're seeing her, those amalgams have been there for 55 years on the 2/6 and the 3/6. What would you do? Okay, okay, okay. So we're getting monitor, OHI, monitor, reassess, retain, leave as is, and monitor. That's fine. The ultrasonic won't remove that. No, maybe the ultrasonic would remove that. You'd probably be able to remove that with curettes as well and smoothen over with the ultrasonic. You won't be able to touch this. You're going to shred the interdental papilla trying to do anything there. Here, with a burr retraction cord, maybe. But why? That's the thing. Why? You have restorations that have been successful. There's no bone loss going on. Everything's fine. Absolutely no harm in this particular patient in sitting on the sidelines and monitoring. The reason for these radiographs is similar to the case where we came across the dentigerous cyst. When I see a patient and the span of the arch going from sort of mesial to distal is very long, and I take a left bite wing and I take a right bite wing, and I'm not seeing enough, I will then take 2 further bite wings on that patient. I will charge them for 2 x-rays. I will take 4, simply because I want to see more. Just in case you miss out on stuff. You couldn't give the patient your clean bill of health when you can't say you've been able to examine those teeth properly, which are in the mouth and functional. Okay, so prognosis of 2-7. Okay, so we've got one response of a questionable, second response poor, coronal seal seems to be poor, not enough remaining tooth structure. Is it just me or is the sound breaking? Is that any better? Okay. Sounds better now. Thank you. Okay, so here we are. Now, the big thing here is, again, I'll come across situations, Griffith's Dental Clinic, and a patient like this has been referred to for perio. We want to put a new crown on there. We want you to do some crown lengthening. And, you know, I'll say to the patient, listen, you know, you got 2 eyes, you lose 1 eye, it's a big deal. Here, there's a tooth, it's had just about everything thrown at it. It's had endo, it's got a post, it's got a crown on it. It's in poor shape. It's extremely weak, extremely weak. That's there. And it is a tooth for the bucket. You need to take that tooth out. Really poor prognosis. Okay, so what condition are these teeth suffering from? Really interesting one. You guys have picked up everything so far, and I'm sure you'll pick this one up as well. Very good. Very good. Taurodontism. Taurodontism. Like the guy who's wearing a pair of trousers, and you can see his backside, and the separation between his legs is down to his knees. So here you have a very long crown. The roots are separating very low down. Taurodontism. Lovely, well picked up, guys. Okay, so nice case. And what you're going to see here is, again, aggressive lesion starting to resorb and dissolve away the apex of the 2, resorption of the apex of the 1. So quite aggressive lesion. Okay, 2 big things here. What are we seeing? Okay, mandibular torus, very good. Pulpstone 1-6, okay. Yeah, it was a torus, Bob. External cervical resorption, yeah, external resorption root resorption, quite aggressive of that tooth. It had to be removed, quite aggressive. Patient is in his 80s. Okay, fine. So early chronic periodontitis. For some of the early year students, I'll be saying to my patients where bone meets anything other than bone, where bone meets the tooth, where the bone meets the gum, it presents itself as a hard compact layer. When you lose that, you know bone is starting to dissolve away, and that bone is dissolving away in response to irritation from bacteria. The deposits harden, so you can see there's a bit of subgingival calculus there. And when you're not cleaning well enough, especially as you get older, your body's not going to fight back so well, and you're starting to lose some bone. And you know, you can help them to bring things under control. Going back to this same patient, we talked to her about caries that she had there. We talked to her about the early chronic periodontitis that she had. All she was concerned about is me talking to her about her wisdom teeth. She had caries there, she had caries there. We talked about all of this. We sent her off for an OPG because all she was interested is having her wisdom teeth removed. But we've seen caries 1.5, we've seen caries 1.7, we've seen caries 2.7, we've seen occlusal caries there on 4.7. That amalgam's fine. It was fine on the radiograph. There's caries on 3.8, caries on the 3.7, mainly all across here, and quite a lot of caries all across there. But all she was interested in was having the wisdom teeth removed. So going back to previous x-ray where we had that one patient, there was a lot of resorption. It was a 4.6 in that case, many slides back. And I said to you, if you wanted to do some silly heroics, you could remove that root and do a root filling on the distal root of that 4.6 and try to get that tooth sitting on the one root, which is what somebody's done here. But in this particular case, I think what will have happened is when I first saw this patient many years ago, what's that, pushing 7 years now, when I investigated, this is what we saw, swimming in a sea of a lot of yuckiness, and it's been posted, it's been root filled. I would imagine it would have been root filled, posted, it cracked, and it was decided, okay, let's try to buy this tooth more time. They've taken out the fractured root and let it sit on here. Of course, that tooth came out pretty much straight away. But now, between there, 2.6 and, 1.6 and 1.6 there, what changes? What is the difference? What is there? Okay. So we've got an Emax crown on that tooth. You can make out the cement lute all across there. Yes. That tooth, although it had a relatively small amalgam in it, had many crack lines in it, no symptoms, and we preempted a problem by crowning it. So same situation, patient comes in 2 bite wings. I'm not seeing enough of the 7, so I take another bite wing. Had you not taken the second bite wing, you're missing this massive cavity on the 7. Yep. Clinically, if you didn't look, then you've missed it radiographically and clinically. One side of the tooth broken there with a lot of decay there. We're not seeing enough of the 1.7. So, or 1.8, we're going further back to pick up the 1.8. And here we can see there's quite a lot of bone loss all across there. But this is the thing, that's that massive cavity that's been picked up. And here we are, huge. Again, prognosis. Hopeless, yeah, okay. Fine. Relatively new cases, brother and sister. Here's the sister, about 2 years younger than the brother. She flosses. Nice teeth, nice bone. You're seeing that lamina dura everywhere. Really looking after teeth. She flosses. Brother, big brother, doesn't floss. Could he be running into trouble? And where? Okay, so we're getting responses here. Distal 1.6. We're seeing distal 4.5, mesial 4.6, distal 4.6. And he's biting on the other side. Same thing. Mesial 5, distal 5, mesial 6. Possibly, I've got overlap, possibly something going on there. Mesial 6, distal 5. And again, you know, he's got to start flossing. Also, relatively recent case, patient came in a lot of pain. So he's had this from trauma. You can see the palps occluding. That area started to occlude, that's occluding, that's occluding. We can probably see intact lamina dura there. We can still see it there. We've lost it on that too. We've lost it here, we've lost it there. So this bloke's had maybe 4 years a large lesion, periapical lesions merging, massive area of destruction in the mandible, and something's changed its nature. It's become chronic, and he's in a lot of pain. I once had a case like this years ago. There had been poor endodontic treatment done. I managed to get the root fillings out, and we started cleaning. The pressure was just too much. In the end, he ended up at an oral surgeon and had 4 incisors removed. So here we are. This patient went off to an endodontist. They were able to fit him in the next morning, and I haven't had a report back yet. This is pretty hot off the press as well. What issues are we seeing, and why have they arisen? Okay, so we're looking at caries, root caries. We're looking at the 1.7 caries. We're looking at the 1.6 caries and the open contact that gave rise to all of this. The patient couldn't, whatever, keep that area clean. So he's got a lot of decay that's gone in below the filling on the 7. He's got this massive amount of decay that's gone in beneath the crown on the 6. I don't know yet if that is starting to interfere with the integrity of the core. It certainly looks like this on the radiograph. But so the first step here was to attack that decay. And I spoke to prosthodontist, and I said, listen, because I sent him the x-ray. So what I did is when I came to working on the 7, I looked at this tooth, and the occlusal part of that amalgam was huge. It covered a massive area. Part of the rim of tooth around the occlusal part of this amalgam was fairly thin. So I opted to preserve that and just to remove the MO portion. So that's a PA I took at the time that was showing me no periapical pathology. He came in for an examination. He was having no symptoms there. And this is what I did. I opted to not weaken that part of the tooth further and came in with what I'm regarding at the moment is just an interim provisional restoration. It's a final filling material, but I'm regarding this as interim, and we've tackled the decay there. I then sent these radiographs on to a prosthodontist, and I said, listen, what would you do in this scenario? Because I've spoken to the patient. I said to them, we might be looking at endo. And I said to him, by the time you look at endo on a molar, plus we rebuild all of this and we make a new crown for you. Sometimes it's less costly to look at an extraction and an implant. And the prosthodontist said, well, why don't you do for the 6 exactly what you've done for the 7? He said that's what he would do. He said, just cut into the crown. And that's what we intend to do. Cut into the crown there and get in here, tackle the decay, and see if it's going into the pulp. Now we're discussing with the patient about endo, rebuild, subgingival restoration, crown with subgingival margins, poor prognosis. Are we going to start talking about extracting the tooth and putting an implant and an implant crown? So everything is going to hinge on whether we have a pulpal exposure when we work on that. Okay, so this patient, this is a radiograph taken a few years ago. Patients come in to see me on Wednesday. You'll see another radiograph of that 5. She's coming to see me on Wednesday, a few days ago. What do you see on that restoration, the 2-5, which was intact on the previous restoration? Okay, so the filling's cracked. If the filling's cracked, what could be happening? Okay, traumatic occlusion. Okay, fine. So we've got bacteria engrossing, caries underneath. And yeah, look, when that's fractured there across there, and I tried to see if that little bit was wobbly, whether it was flopping up and down. It wasn't, but and we took our radiograph, our new bite-wing. There's the kink there, that's where the fracture is. And this is where the caries has developed. And same patient. So we're seeing on this patient now with this new picture, there's bone loss there. The rest of the bone loss is out of the picture. So we're taking another picture. Okay, so that distal buccal root is pretty much out of bone completely, pretty much. There's only a itsy, 4 millimeters, if that, still in bone. Trifurcation involvement in a big way, big sort of deep pocket across the prognosis. Okay. What would you do? How would you treat that tooth? So I'm getting root canal treatment, remove the fillings. There's no issue there with the filling. The problem is bone. um, um, maybe severe periodontal bone loss. You could debride. That alone is not going to get any bone filling in there. Extraction, it's unlikely that you're going to get an OHC, unlikely. So often you'll see this where the sinus flow is sort of just undulating and the roots appear to be poking up into there, but they're either side of that. But yeah, look, bone grafting, we've referred her to a periodontist, and we'll let the periodontist make that decision on what they can do for her. Again, you know, when you've got a vertical pocket, bone grafting possible, bone grafting there possible, but when you've got that horizontal bone loss, it becomes very hard unless you're using membranes. Okay, so what type of root filling points? Okay, silver points. Okay. And so again, when you're seeing this, you'll want to take PAs or an OPG. And this one here now, is there any hope for this tooth? Yeah. Someone says, wow. And I reckon somebody says, wow, wow. This is up here for me to show you that this student probably took the patient to post-grad endo or dentist. And you need a special talent, really. Honestly, you need to be able to twist a GP and still get it entering there. And you need a special talent to get a GP point to curve like this one does and come back on itself and go into there. Gosh, is me. I've got this in one of my other lectures under how not to do dentistry. And we're coming towards the end. Yep, here we are. There's Spider Woman, alive and well, living on the Gold Coast. And I think this slide also is there that, you know, we have a part to play in the whole healthcare field. And we look after people in this very, very specialized area that we work in. But, you know, take it all with a little pinch of salt. Again, earlier I've mentioned, you know, somebody's got 2 hands, 2 arms, 2 eyes. If they lose one, it's significant. But if they lose a tooth like that, you know, it's no big deal. So here we are. There are people, years of, you know, there's probably an orbital fracture. And this is the phenomenal work that our medical colleagues are doing. You know, that's what they're doing. We're playing our bit, and yeah. So there's a lot of big work, and I take my hat off to our oral surgeons, our maxillofacial surgeons, the general surgeons, really. So here we are. Thanks very much. We've come to the end of that part.
Excellent. Thank you so much, Dr. Mohammed. If anyone has any questions, please feel free to pop them in the chat box. I know we've been answering as we've been going, but if there's any extra questions, feel free to pop that in the chat. We're getting a lot of thank yous, Dr. Mohammed. That was a fantastic presentation.
Thank you all for staying with me through all of this.
So we've just got one question. The radiograph from previously, I think the last one you showed, where was where there was a post-perforation, how did you manage it?
That post-perforation was very superficial. We took out the restoration. We pulled the post out. I'll see if I can go back to that one for you. So like I said, I hope that when you guys are back on clinic, you'll be looking at things a little bit more broadly. Sorry, that's taking a little while. Basically, the post was relatively superficial. There wasn't a lot of damage done. We were able to remove all of that. There we go. Okay, fine. To do a really good restoration on this tooth would have involved re-endo, getting a nice post and core in there and putting a crown on. The cost for the patient are prohibitive. So what we did is we had taken out the restoration that was there. I think the buccal wall was still present. We removed the post, we cleaned everything up. I put a pin in the tooth there, I put a pin in the tooth there, and we rebuilt the tooth for her. Shall we move on, Claire?
Yes, we can. So we've had a couple more questions.
Okay, yes, yes.
What's the management for pulp obliteration?
When the pulp's closed up, if there's no periapical pathology, there's nothing to worry about. If there is periapical pathology, you've got to make sure that if you're going to do that yourself, that you are going to not create too much of a big axis, you're not going to deviate, you're not going to create a perforation. And if you're not confident in finding that canal, or after you've done your axis, you can't find the canal, then certainly refer the patient on to an endodontist.
So we've got a couple more. It says, which is the best x-ray for perio patient to assess bone loss progression?
A bite ring radiograph, and when you have the bite ring tabs that I showed you, you don't necessarily always have to put the bite ring tab in the center of the film where you're wanting to capture the upper and lower teeth all on the one radiograph. So I will set the bite ring tab off center. If I want to see more of the lower teeth, then I will place my tab towards the top of the film, and the patient bites down. The film is going lower down to show me more of the maxillary. Remember, you get a true view of the bone level when you are coming in at a 10-degree downward shift on your X-ray tube. And if you keep to that 10-degree downward shift all the time on all the radiographs that you're taking for bite ring and bone loss views, you'll be able to do comparisons year after year.
A couple more. Any specific material used to seal the perforation? So I think it's back to the post-perforation question.
Nowadays would be MTA.
just out of my own interest, is there anything that's on the more, I guess, least expensive side instead of MTA? You know, it's quite a more of an expensive material. Not all practices have them.
Yeah, I think by the time a patient's got a big problem and they're needing to spend quite a lot of money, that MTA is not a huge additional expense. The case of the apicectomies that you saw were done on some cases, and the one that I did are in the days before MTA came around. We certainly wouldn't be using that today. So MTA is the thing that you would want to use.
Perfect. Thank you, Dr. Mohammed. Sorry, just scrolling through a few more. For the 2 upper molars with food trap related caries, is it possible to remove and restore the 1/6 with a ceramic crown after the mesial part of the amalgam restoration is removed? And you can get some direct access to the distal part of the 1/6.
Okay, so was this the case where we had the food trap between 1/6 and 1/7, and we've removed the decay on the mesial of the 7 as a provisional, and we want to provisionally go in on the distal of the 6, initially looking to see if we're going to have an exposure, no exposure, whether we're going to have to do endo or no endo, because the costs are going to come into it. If everything's going to be simple and straightforward and there's no endo involvement, we'll put a new crown on probably the 6 and the 7. But if there's going to be endo issues on that 6, then the patient may opt for extraction and an implant for the 6, which would be the more preferable things to do.
Thank you. Another question, sorry, I'm going a bit back and forth, but with regards to assessing risk of oroantral communication, you mentioned on a previous OPG that the risk was low, even though the roots appeared to be adjacent to the sinus. How can you tell?
Tougher one. So if you grab hold of 100 OPGs, probably on about 80 or 85 of them, you're going to see the sinus flow undulating between the roots. And OAC is not that common. I've come across it maybe no more than a dozen patients who've had an OAC in close on 40 years of practice. I don't know if that answers your question. I think you shouldn't be as fearful as you are. It depends how carefully you're removing everything, and just checking carefully after too. When you've got a lone standing tooth and the sinus flow has come down, as was the case with a 2.7, 2.5 area where the sinus flow had come down almost down to the ridge, then you've not only got a lone standing tooth if the 7 needed to be removed, but you've got the sinus flow low down. Then your risk is quite high.
Perfect, thank you. I've got a question from Delvin here. When you were mentioning about building the marginal ridge of the restoring tooth, restoring tooth of the opposing cusp, how can you assess this, especially if your bite wings could not capture that relationship?
I feel sad that certainly at Griffiths on clinic, you guys don't have those bite wing tabs, but you've got bite wing foam, and you can stick that bite wing foam on your radiographs and get the patient to close. And when you're getting the patient to close, it's helping you to assess. But look at occlusion before you start. When you're needing to build up a tooth, MODO, anteriors, whatever you're doing, get the patient to close. Have your mirror in the mouth. Look at how things are to start with. Look at the space that you have. See where the opposing cusps are biting in where. And then you are pre-warned. And then go cautiously after that. The other thing, just going on from there, and I've been hearing this for too many years with the students, is please tap, 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 grind this way and that way. Don't tap, tap, tap. I ask my patient, can you gently close? Can you gently slide your teeth from side to side? There's no tap, 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 because if you've got something in the way, you don't want them sustaining a little chip or fracture on your lovely new filling straight away before they've even gone out the door. So often with my students, I will ask them, okay, you're going to work on this area. Before you start, ask the patient to close, or just going further, look at the other side of the mouth. Look at how the teeth are coming together. So once you've filled your tooth, get them to close again. Ask them to gently close. Look at the other side. See what you saw. Is it different? Is there a millimeter, half a millimeter, 2 millimeter gap between the teeth compared to before? If they're not coming together, what you've just put in is very, very high.
Beautiful, thank you for that. Another question from Sherry. With self-resorption of unerupted eights as seen on the OPG, is extraction indicated or just monitor?
In the absence of symptoms, leave things completely alone. The only one of any of those that came out was the guy who had the symptomatic 180. He came in, he was uncomfortable, he was in pain. I took the bite wing, it didn't go far back. I took the PA, which now captured the 8, that led on to the OPG, and he had that tooth removed. Fortunately, it didn't have fancy mangle roots, and that was removed by the oral surgeon. But when they're buried, leave them well alone. All those patients you saw the resorption on, the teeth dissolving away, were elderly patients. It had been happening for quite a long time.
I've got another question with regards to carious lesion under crown. Will there be the 3 following options? 1, direct access. 2, cut part of the crown and then restore. Or 3, remove the crown but explain to patient that you may not be able to put the new, may not be able to put it back and may need a new crown.
Okay, so you are in the case where the crown is present, there's deep cemental caries extending subgingivally. You will try to prise the crown off in the hope that you can reuse it. It's not going to be fitting anywhere near like before, so that's a no-no. The removing the caries, cutting through the crown to get at the decay is step 1. Remove the decay and see, have you been able to take a follow-up x-ray? Have you done a decent job? Have you been able to eliminate all the decay? Is the tooth nicely sealed? Then, was there a pulpal exposure? Is it going to need endodontic treatment? So let's talk figures here. That case of the 1/6, if I'm referring the patient to an endodontist for root canal treatment, we're looking $2,500. We're looking to be putting a new crown on that tooth after the tooth is rebuilt at $1,550. So he's getting to about just over $4,000 for that. Not everybody is walking around with that sort of disposable income. But if he were, he's maybe better off losing that tooth and putting an implant in there for about, some patients can have that done for under $4,000, or others going between $4,000 and $5,000 with a much better prognosis long term. So everything hinges on endo. If it doesn't need endo, get a provisional restoration in, try to build up a nice contact, review him because you were so deep, you were so close to the pulp, it might blow up. Just watch that, monitor him, take a follow-up radiograph, see him again. And if it's okay, and if you think you can maybe make a decent crown. Now going subgingially, are you going to do that? Are you going to send him to a periodontist to crown lengthen? Now we're getting into doing a lot of work on a tooth where maybe an option is an extraction. But everything hinges on whether it's just going to need a filling, and then can you put a decent crown on there after?
So going back to the OPG, Dr. Mohammed, with the oral communication, we've got a question asking, for high-risk OAC, is it more likely when the sinus floor is not continuous, unlike here, I'm guessing in the OPG, where the floor of the sinus is fairly clear and continuous?
Tough one to answer, sorry. I think in the case of that one, the tooth fractured, and in the attempts in trying to get the root out, the dentist actually ended up pushing it into the sinus. It wouldn't have happened otherwise had things come out without what was done, the instrumentation that was done that led to the OAC.
Okay, and I think our last question from Dalvin again. In my pediatric clinics, I've seen 14-year-old male with missing upper canines, spontaneous resorption of the roots. Why would this have happened? There was no trauma of history of trauma. It was missing upper permanent canines, and there was retained upper primary canines.
And it was it the primary canine roots that were resorbing?
Yes.
Okay, so maybe the primary canines were living to the message that they had been given, that you're going to live for so long, and then this is going to happen. They're going to resorb. Maybe, I don't know. No other answer to that.
Thanks for the question, Dalvin. And thank you everyone for participating today, and a big thank you to Dr. Mohammed. I think that ends our questions for the evening. I think I can speak on behalf of everyone when I can say that was very insightful, and I thoroughly enjoyed that myself as well. So thank you once again for giving us your time on a Saturday evening.
Thank you. Thanks everybody for listening in. We've gone on for quite a long time, haven't we? Yeah.
We have indeed, but I think it was a very good one. So I think we all really appreciate it. And we've had a lot of attendees. I can actually see someone's listening from the Philippines. So we've even reached international listeners.
That's nice. That's really good. Well, I hope everyone leaves having gained something and taking something positive away from all of this.
Beautiful. Thank you so much, everyone. I think that's it from us tonight. Have a good night.
Okay.